Good afternoon. It's a real pleasure to welcome you here today to our third annual Usher Lecture. For those of you who don't know me, my name's Aziz, Sheikh, and I have the privilege of being the director of the Usher Institute. And a very warm welcome to colleagues from across the Usher, but also more widely across the college and the university. And then a number of colleagues are joining us online. This is being live streamed. So you're very, very welcome. And in particular to our Usher lecturer for this year, Chris Whitty. Chris, it's absolutely fantastic to have you here, and really looking forward to your lecture a bit later on. What I thought I'd do is just to try and set the scene is tell you a little bit about the Usher and its origins and what we're trying to achieve, and then reflect on the theme for today, which is really around global health. So the Usher Institute was established in 2015, so it's a relatively new institute in our college and university. And what it is it's probably the most applied and translational grouping that there is in our college. So really we're very interested in thinking around how we can strengthen health systems, deliver benefits for patients and populations. And we do that both locally and globally. So later on this week, we will be hosting the Lancet Commission on the Future of the NHS, which is visiting us for 3 days to think about how we actually begin to strengthen the NHS. But our theme today is around our global aspirations. And so what we have in the Usher Institute are now 4 centres. So we started off with a centre for population health sciences, and that was created through the amalgamation of our public health academic expertise and primary care academic expertise. And Edinburgh has a very distinguished history in this respect, and that these are the first academic groupings of public health and primary care anywhere in the world. So really we've tried to build on that heritage and expanded to create a group of Centre of Medical Informatics and a Centre for Global Health. And global health is really the theme for today, quite obviously. And earlier this year we created a new centre, a Centre for Biomedicine, Self and Society, focusing on the social sciences. Now that's very relevant in the context of this building, for example, the Appleton Tower, named after the Nobel Prize winning physicist and the previous principal of the University of Edinburgh, Sir Edward Appleton. And he had this vision around 2 sort of edifices of learning, one to do with the sciences and the other to do with the arts, so the Hume Tower. So those 2 sort of constructions, and if you actually read about them, I mean, it was actually a very controversial building at the time, described as probably 2 sort of monstrosities really in terms of their architecture, but it has been refurbished, and now we have a very skilled senior vice principal, Jonathan Seckel, who's in charge of sort of our new building project. So it's one of his many remits. So Jonathan, great to have you here in the mix. So global health is an absolutely phenomenal opportunity for us. This is a global university. We've always had global aspirations. And global health is one of these areas where, I mean, as a result of, why it's, I guess, particularly attractive is that the headroom for making a difference is absolutely phenomenal. So there's the opportunity not only to develop capacity and capability, but really to begin to transform lives and health systems. And what we hope is today, what we'll have is begin to showcase in the first half of the meeting some of what's going on in our Centre for Global Health Research and across the Usher. Hopefully inform, give the opportunities to invite critical reflection. We want to do better. So we actively encourage that. And we hope also begin to whet appetites. So for those of you not engaged in this agenda, that hopefully you see some opportunities, because it is very much an open structures, and we encourage collaboration. So hopefully that will begin to happen. In relation to our Usher annual lecture, this was instituted by the previous director of the Usher Institute, Andrew Morris. And I think it's been absolutely fantastic, really. It brings us together across the Usher and wider friends and colleagues. So this is the 3rd annual lecture. So the first was given by Johnny Anides from Stanford, dealing with issues to do with reproducibility of science, particularly in this big data era. And that's so relevant for us as our senior leaders in the university have just signed the City deal. which you'll have heard about. So Theresa May and Nicola Sturgeon were up a couple of weeks ago to launch that phenomenal initiative. So John Ioannidis continues to chair our International Advisory Board, a great friend and colleague, so he gave the first one. And then last year we had David Blumenthal from Harvard Medical School and president of the Commonwealth Fund, talking about high need, high cost patients, a universal challenge. And these patients, he reminded us, are probably something to between sort of 2 to 3% of patients, but are consuming something like 50% of healthcare expenditure. So for our health systems to become sustainable, it's absolutely crucial that we begin to grapple and more proactively manage those patients. And this year, I'm absolutely delighted that Chris has joined us, and Chris will be sharing his vision of the sort of 20-year horizon for global health from his unique vantage point. So Chris will be introduced in due course by the principal, so I won't sort of go into that any further now. So I hope that begins to sort of set the scene about what we're about and what we're trying to do today. So I think a vibrant community, but we are incredibly ambitious. We want to engage, we want to improve. And so there will be the opportunity, I hope, to meet with colleagues. There's a kind of a generous break, and there's also a drinks reception that follows. So what we're going to do is kick off with our series of very short presentations, and then what I'll invite is our speakers to come forward and form a panel. So if there are questions, comments, thoughts that you've got as we're going along, please do hold those, because we will have a dedicated half an hour, hopefully, for panel discussion before the coffee break. So just to warn our speakers, you have been allocated 7 minutes. Dom is there, and she'll be holding up cards with 3 minute, 2 minute, and 1 minute warnings, and then there's a red card. So we're back in football season, and so I'll have to come on and send you off. I actually am very encouraged, because Derby County is now, has new management in place. So hopefully this will be a better football season for Derby County, at least anyway. Okay, so 7 minutes, and I think probably that's all I've got to say by way of introduction, but absolutely fantastic to see you all here, and I hope it will be a really stimulating afternoon. So first up, we've got Igor Rudan, and Igor is our co-director of our Centre for Global Health Research. He's also leading a WHO Collaborating Centre for Global Health, and is also director of research for the Usher Institute. So Igor, thanks very much indeed.
Thank you so much. Thank you for coming here. I'll start with presenting WHO Collaborative Center for Population Health Research and Training, which I'm co-leading with Professor Harry Campbell, who's really taught me everything that I know about global health myself, and not just me, but so many of us who work in this center. Thank you, Harry. So our main activities that we're known of in international community is we measure global health. We measure the size of the problems. We do some work in governing of global health and priority setting, innovating for global health, and finally, we are really serious about education in global health as well. There are people who are supporting these streams. Everyone is involved in education, obviously, but also in epidemiology, you could see we have quite a number of people. Governance is developing under leadership of Professor Devi Sridhar. Innovations, there is also a stream of people there. We started off about 3.5 years ago as a handful of people, really 6 people. Now our goal is to try to reach about 100 PhD students, administrators, research fellows, readers, chancellor fellows, and professors. We're getting there slowly. We're about halfway there. These blue people, those are people who are not with us as staff members, but they're adjunct or visiting professors and work very closely with us. So we're growing slowly and steadily. We have a number of funding sources to turn to, luckily. In terms of measuring global health, these are just some of the examples, and the Governing Global Health, the Wellcome Trust, the World Bank, and finally Innovating for Global Health, MRC, CRUK, European Commission are the big donors. The purpose of this slide is really to show you that there is a diversity of funding in global health, and there's no shortage of interest to support it. In terms of epidemiology of leading global health problems, we're expected to build these kinds of maps to advise how big is the problem globally or regionally or nationally, and then this informs various policymakers and lets them know what they should be focusing on. In terms of governing and priority setting global health, we're known for great work that Devi is doing on governance and understanding how institutions work, and also on developing some tools that are helping policymakers and investors make priorities about what should they support. Lives Saved tool is something that we've been developing with Johns Hopkins University, but Equist, Chunri, and Planet are tools that are advising investors how to invest in research, how to invest effectively in interventions, and how to monitor programs that are being rolled out. Innovating for global health, we are advising World Health Organization and other institutions on building biobanks in low and middle income countries, which can help understand molecular aspects of child and maternal and newborn health. We're doing it in Pakistan, Bangladesh, and Tanzania. Also, we are getting increasingly serious about becoming a teaching hub in global health. We have undergraduate year 1 and year 2 programs. We have 4 global health related programs in a master's program. Also, Liz Grant, who's just going to speak after me, and Ruth McClellan have been running MPH and PhD in global health with the Global Health Academy. We have set up a student society in global health, which has 250 students, and we are also advising World Health Organization and other organizations as a collaborating center in developing their manuals and sitting on various committees. Just to give you a taste of what these committees look like, for example, we're sitting on pandemic influenza preparedness, surveillance of respiratory pathogens such as the respiratory syncytial virus, RSV vaccine expert group, childhood pneumonia expert group. We are a member of collaboration of WHO collaborating centers in Euro region on maternal, newborn, and child health. We've been working for 17 years now on the MCE project, Maternal Child Health Estimates. We have been advising them on setting priorities globally for dementia research, maternal, newborn, and child health research, developing biobanks, as I said, and finally we have helped them to develop several guidelines, such as Global Health Metrics Guidelines, GATHER, Neonatal Infections Guidelines, Refugee Camps Disease Burden. And this is just a summary, really, because we do quite a lot more with the World Health Organization, and also with the World Bank, and with the UNICEF and the Gates Foundation, and Save the Children. So we are quite active in working with them and advising their work. We have started publishing to support our teaching programs. You can see here 4 books that we have launched in the last few years. And some of these books are now being turned into massive open online courses. Survival, the Story of Global Health is an example. It's already been seen by 50,000 people on YouTube. And Investing in Global Health and Development is the next in line based on this Healthy Ideas book. Survival, you can check it for yourself, is a YouTube channel. As I said, it's been already picked up by 50,000 people. We tried to work with BBC, and Wellcome Trust has supported us in developing a 2-hour documentary introduction to global health, and we are hoping to air it even on some televisions. In terms of disseminating knowledge, we have launched, really out of thin air, here 8 years ago, the Journal of Global Health. So we started it at the 19th World Congress of Epidemiology in Edinburgh, and little by little we grew it through open access system to something that now has 300,000 visitors a year from 187 countries. We receive more than 1,000 submissions a year. Our official impact factor is now 4.2, which makes us second journal in any area of science for Scotland, and we reject more than 90% of our papers. We're hoping to build this into an impact case study and spin it out as a JOG brand and develop a family of journals around it, because it ticks several boxes for an impact case study: global wide reach, and spin out companies, job creation. It's all possible through this that we've developed. Future plans for this center in terms of global health, I'd like to say that it's an excellent area of research for teaching, for consultancy income, and for spinning out even companies based on the innovations that we can bring to global health. And there's a real opportunity for us to lead. Also, it's a well-funded field in comparison to most other research fields, remarkable variety of donors. We are hoping to reach a size of around 100 staff and PhD students with about 10 recognizable international programs that are led from our center. Aspiration is that on the basis of Journal of Global Health's visibility internationally, we build an annual international conference on global health, because there's a real need out there. We had Global Forum for Health Research, but that ceased to exist. And I think Yale has done well, and now we should also follow that example and build one here in Edinburgh. And finally, I think there's also opportunity to link all this with a summer school that could be run here in July when students are away because of the space that would be available, and bring in people from all over the world to be taught our programs. Thank you very much.
Thanks very much, Igor, for getting us off to a fantastic start. So next up, we've got Liz Grant, who's our director of our Global Health Academy and is also assistant principal for Global Health. And just while Liz is getting mic'd up, Liz just convened this fantastic Lancet Planetary Health meeting, which was in Edinburgh in just a couple of months ago. So thanks very much indeed, Liz.
Thank you. And it's great to see you all here. So I just want to very briefly give you a little description of what the Global Health Academy does. The Health Academy is one of 5 academies in the university, which, if you can imagine a coin with 5 sides, the purpose is that each side, the Justice Academy, the Environment and Society, the Agriculture Academy and the Development Academy and the Health Academy have outward faces but work internally together. To really emphasise that Edinburgh University does cross-disciplinary work together, because the global challenges will only be reached by working together. The Global Health Academy is based on 3 premises, and I just want to quickly take you through them. One is that we are born equal. Humanity is equal. And actually, anything we do in global health, we have to believe that. We have to have a concern that our brothers and sisters in any part of the world, we are together with them, because otherwise, why are we doing what we're doing? And that's a fundamental part of all our global work. And actually, it's embedded in a lot of our global health partnerships, a lot of our bids. We're born equal, but we're born into quite a complex world where the answers to many of the world's problems are probably in the world already. They're just not with the people that we're necessarily going out to speak to. Who do we need to speak to? How do we hear the voice of those who's most vulnerable? Because those who are most vulnerable often have creative, innovative ways of doing things. So sharing knowledge, hearing, learning, and really be responding to the fact that many answers are there. And alongside that, we know that intertwined challenges need interconnected people. The sort of perfect storm that is coming, that when we look at what's happening with climate change, what's happening with energy use, what's happening with pollution, what's happening with global health metrics, we know we need to work together. So very much the Global Health Academy offers this space for staff, students, alumni, partners in different countries to come together to share ideas and knowledge. This is just a very brief overview of what the Academy does, and I want to just give 3 snapshots of some of those areas. You can pick up one of the brochures outside if you'd like. But it's that sense we work across our learning, we work across supporting research, and we work across building and supporting partnership development. Just a little snapshot on numbers. One of the exciting things for the Academy has been, over the 9 years we've been in existence, is fostering online master's programs. Online programs that allow us to enable students, particularly from low and middle income countries, to become part of our community. So these, the programs, the master's programs, are run through first year certificate, next year diploma, and then masters in the 3rd year. Very much focused as well around how do we enable students to draw their knowledge that they're learning into their working environment, and draw the working environment experience into the knowledge that they can share with other students. So there's exciting peer learning going on as well. So that's been one of our student community in the master's programs online have been one of the areas, and particularly I want to emphasize family medicine as we across the globe look at strengthening primary health care, strengthening family medicine. We also are, as I say, supporting research, where there's some research that's happening within the Academy with the leads of the Academy, with the different members of the Academy who have their own research. But as an Academy unit, what we're doing is actually providing the back office work, as it were, for supporting and enabling research to happen. Running workshops around writing grant applications, running workshops around monitoring and evaluation, enabling and supporting people to join together with partners in different countries so that so grants can emerge up. And we've been funded from various sources. I want to give you a couple of little illustrations. Actually, as we're sitting here, across in Uganda at the minute, our Commonwealth Commission funded summer school is running. And this has been one of the summer schools that have run over the last number of years, almost 10 years, where we have students who are on our master's programs who have been funded through the Commonwealth Commission, and we, as you saw on the last slide, very successful in attracting Commonwealth Commission funding. These students come together from different degrees, different master's programs, to share in their learning and knowledge and to share with each other about how do we tackle global health problems. And I've put a picture here of Carol Nsimi, who is one of our students who won the World Academy of Science Samira Omar Award for her work around looking at infectious diseases among and the transection across with the gorilla populations in the Badongo, where our summer school students will be going up to visit in the next few days. This is important, though, because as Aziz mentioned, and we'll come to it, planetary health matters, this intersection. So we know that as students look at these programs and look at and work together during this week and then continue the work on, we know that we're beginning to draw and enable our students who will become our alumni to be part of work. So we have, from the student community, we've got work happening with or beginning hopefully to happen with the Ministry of Health in Kenya that Rebecca Reynolds is linking with one of our Commonwealth Commission students around diabetes. We're hoping that it does get funded. That real sense of Edinburgh being in different parts of the world, and we're working with these multiple areas, but recognising they have a shared base. Planetary health. Richard Horton made this comment, and I like it, that we should feel that we have got this radical liberty to choose how we move forward in a world that needs to be reconceived. Planetary health is about looking at these intersections of the different frames of health, recognising it's not just human health, but health of the planet, health of the air, the sea, the rivers, the oceans, health of the economy that we need to be engaged in together. You're going to hear more about Tiba soon, but my co-director, Francesca Matapi, is also one of the directors of Tiba, and one of the things our academy does is actually provide that capacity building support as well as one of the with the work programs in Tiba. You'll hear a little bit more about Respire, obviously, but I wanted to flag up a couple of other areas where we're working in Diplomatic, which is a program in Malawi, working to reduce mortality of children under 5 and reduce preterm birth. And that program led by Jane Norman, where our academy is part of the program. Another exciting program on cervical cancer screening that Christine Campbell is leading. Sorry, my time is now gone. I want to, we've palliative care programs running, and we've got a whole group of themes, and I've grouped them in under these seven programs just to give us a little taster of some of the things we do. So thank you.
Thanks very much indeed, Liz. And Liz was very modest, so that quote from Richard Horton led by Liz Grant, which she omitted. So next we've got Lawrence Gruer. Lawrence is our Honorary Professor of Public Health here, and is part of the executive group for the recent first Congress on Migration, Ethnicity, Race and Health, which Raj Gopal, our Emergency Professor for Public Health, led. So Lawrence, thanks very much indeed. Thank you.
Thanks very much. So our group, Edinburgh Migration, Ethnicity and Health Research Group, which is inevitably called EMERGE, was established quite a long time ago, 2003, and throughout its lifetime it has been led by this devastating duo of Raj Gopal and Aziz Sheikh. And early on they articulated their vision to create a cooperative coalition of researchers and scholars working in and around Edinburgh to improve the quality and quantity of research on ethnicity and health at a time where there was very little work of this type going on anywhere. And over the years, there's probably been about 20 to 35 members many of whom have come and gone, including numerous students and visiting scholars. And they've brought together 3 or 4 times a year in lunchtime meetings, and they've produced various newsletters from time to time to summarize what they're doing. A wide range of different studies have been under their aegis. The key ones are probably these. The Scottish Health and Ethnicity Linkage Study, about which I'll say a little bit more, prevention of obesity and diabetes in South Asians, the end-of-life care of South Asians and asthma, collaboration in the Bourne in Bradford study, and modifying health promotion interventions in ethnic minorities. So SHELS, the Scottish Health and Ethnicity Linkage Study, has been going on, as you can see, for a long time, and we reached the end of our last grant last year. It involves an unprecedented anonymous linkage of the 2001 Scotland census with routine health and death records. The census includes in Scotland the self-defined ethnic group of the individuals in the population. So we've been able to create a cohort of 4.62 million people and thus compare up to 13 distinct ethnic groups in Scotland. And we've had 4 funding phases to do that on a wide range of different outcomes, which you see here, ranging from all-cause mortality right through to specific issues such as breast and bowel cancer screening. Just to give you a flavor of the types of results that we've found, here are age-adjusted rate ratios for any cancer over a 7-year period in Scotland. And you can see the reference population of the white Scottish with the reference rate of 100 across the middle of this line is the dotted line. And you can see pretty clearly there that most of the other ethnic groups in Scotland have got much lower rates of cancer, particularly the Indians, both males and females, and the Pakistanis. Whereas if we now look at first myocardial infarction, you see a rather different pattern here, where there are a number of ethnic groups with substantially higher rates of MI than the white Scots, who already have high rates on an international comparison basis. So the Pakistanis, both males and females, have the highest rates in Scotland. But look at the Chinese over on there on the right, who have about 50% of the rates of the white Scots, and therefore only about a third of the rates of the Pakistanis. Now these raise very serious questions of causality and also have implications for both policy and practice. So overall, there will be 27 papers, I think, on SHELS. 3 are still in the pipeline. And this one here, recently published in Lancet Public Health, I think will probably end up being one of the most influential that we've written. But that international influence can be translated through over 200 publications now from the members of the group, through a wide range of visiting scholars who've worked with the group in various guises over the years, numerous conference and speaking engagements, and particularly involvement with the Migrant and Ethnic Health section of the European Public Health Association, with considerable participation in 6 European congresses. The last one was 2.5 years ago in Oslo. But perhaps the apotheosis, the high point of the group was in May, with the brainchild of Raj Gopal, this first World Congress of Migration, Ethnicity, Race and Health. And Raj and I were the conference company directors, but a number of the other members of the group played key roles as well. We attracted over 700 participants from 53 countries, and we crammed into 3 days over 600 oral and poster presentations and workshops across 19, something that would have been completely inconceivable when this group first started. Such has been the development of this particular area, and the interest now a very high priority with all the migration of populations in vast numbers going on across the globe. So this led to the Edinburgh Declaration with 6 important recommendations for action in the future, including agreement to set up a global society to integrate academic, professional and community work on this area throughout the world. So in conclusion, I think we have the initiators of this group showing vision which has then been translated into reality through their innovation and their tenacity, and through collaboration with people throughout the UK and many other parts of the world, leading to a growing amount of influence in this area of work in many parts of the globe. So I think we owe a big debt of gratitude to Raj and to Aziz for kicking this thing off and giving it such excellent leadership over the past 15 years. Thank you very much.
Thanks very much indeed, Lawrence. So there will be the opportunity for questions and discussion a bit later on. So next up, we've got Harry Campbell. Harry is co-director of the Centre for Global Health Research, also co-director of Respire, and has been instrumental in putting together today's programme. So thanks very much indeed, Harry.
Okay, thank you. We were very thankful to NIHR for the support to set up Respire. So I'm going to take you through the first year of the Global Health Research Unit on Respiratory Health. It's a partnership with UCL, the International Primary Care Respiratory Group, and our partners in Bangladesh, India, Malaysia, and Pakistan. The challenge we're addressing is 1 in 5 deaths in South Asia are due to respiratory conditions. So, for example, chronic obstructive lung disease is the 3rd largest cause of death in Bangladesh in 2016, as shown in this GBD graphic. And the professional and the policy awareness of this in Bangladesh is very low. Another challenge is that interventions known to be effective against respiratory conditions are not being implemented in South Asian countries. And implementation issues are complex and they're specific to each setting. So taking an example within Respire, we are funding an effectiveness and implementation study based on a trial carried out by one of our partners, Mohammed Chisti. He published this in The Lancet in 2015, showing that a low-cost technology, bubble CPAP, can be used in children with severe pneumonia to reduce mortality. But we know globally through our contacts that other studies have found that using bubble CPAP actually increases mortality. So we're currently in discussion with the Gates Foundation to have a global meeting to try and understand some of the factors so that these can be used to inform the implementation and effectiveness work that we plan in Bangladesh. So our ethos is that we believe there's a substantial opportunity through scaling up of interventions like bubble CPAP to make a significant impact on respiratory health outcomes and contribute to improving lives in South Asian populations. And we intend to do that through building local capacity, stakeholder engagement, and implementation and effectiveness research. And we'll achieve this through activities that are both directly relevant and primarily relevant to the needs of our partners. And we'll pursue this by adopting the principles that NIHR are putting forward for ODA. Locally identified problems, equitable partnerships, pro-poor focus, capacity building, and having a translational focus on impact. So the structure of Respire is 2 programs, 1 on acute respiratory infections, 1 on chronic respiratory diseases, and 3 cross-cutting platforms on stakeholder engagement and PPI, methodology and data science, and training and capacity building. And through this, to set up networks of practice and research in the 4 countries in South Asia we're working in. And as well as this program and partnership structure, we have an international steering committee chaired by Zulfikar Bhutta, and we have our unit management committee. We're supported by an excellent professional services team who are here today. The University of Edinburgh are providing additional support in a number of ways, including appointment of 3 mid-career researchers to the project and making 2 PhD studentships available. And they're actually giving us grant funding, for example, to allow us to become an early adopter of the good financial guidelines practice in Respire. This NIHR investment essentially has allowed us to build on 20 years of work on chronic respiratory disease that Aziz has undertaken, and capitalising on the Asthma UK Centre for Applied Research that he co-leads, and my work over a similar period of time on acute respiratory infections in children, and my links over this period with WHO and using evidence to inform WHO policy and clinical practice guidelines. So we had a kick-off meeting in September in Edinburgh, and we used that to develop a common vision, strengthen our relationships, but to focus on capacity building. We aim to build capacity across the life course of research staff, but inevitably, because of the short time frame of the project, we focused on PhD studentships. So these were externally peer-reviewed, they were competitive, and we've made an award of 10 PhD studentships across Respire. Then we met in February in Dhaka to identify a number of small projects that we'd fund and take forward. But as part of that meeting, we had a policy dialogue workshop. We had senior members of government, of Ministry of Health, and of the National Professional Associations for a half-day policy workshop. And that's led directly to workshops now with the Ministry of Health. So, for example, for Bubble CPAP, we're starting that project with a Ministry of Health workshop to get ownership and buy-in from that project right at the start. So we've now funded 7 small projects across Respire, again through an externally peer-reviewed competitive process. Then we met in Porto in May this year at our annual scientific meeting. We chose Porto because the International Primary Care Respiratory Group had a large meeting there and there was opportunities for networking. And at that meeting we focused on large projects. So again, externally peer-reviewed competitive process, we funded 7 projects that we're taking forward throughout Respire across the 4 countries. So it's been a very busy first year, due diligence, governance, sponsorship, administrative duties, but we're investing in these hoping that this will be a long-term project. In February of this year, we put in our 6-month checkpoint report to NIHR. And then last month in August, we put in our annual report. Recent events have been the IPCRG World Conference that we took an active role in and networked in. We had a Global Respiratory Health Synergies workshop that I'll finish with, and we just recently in UAE held an air quality methodology research workshop. So we identified groups around the UK that are working on respiratory health, and we invited 8 groups. 7 of them are funded by NIHR as global health units and groups, and we invited them to Edinburgh in implausibly good weather here, because we believe that what we could achieve together is greater than what we could achieve separately. So we had identified a number of areas for collaboration. In terms of operational areas, sharing experience with the Good Financial Guidelines practice and the International Aid Transparency Initiative adherence, sharing problems and challenges, setting up a research manager support network, sharing training courses and other materials. At a scientific level, setting up a register of studies, fostering agreement on case definitions, developing reporting guidelines, looking at joint grant applications, and sharing training opportunities across the network. And then at a strategic level, working together to raise awareness of respiratory health, coordinating our stakeholder engagement both nationally and globally, and aiming to work together to set the global agenda in respiratory health. I'd like to end by saying that we're really bought into the NIHR lead on equitable partnerships. And to give Chris Whitty some early feedback, one of our partners told us, in 15 years of collaborative research with international partners, this is the first time I have been asked what I would like to do. Thank you.
Thanks very much indeed, Harry. Fantastic. So next up, it's a pleasure to welcome Mark Woolhouse. Mark's Professor of Infectious Disease Epidemiology and is also Director of one of our other NIHR units, Tiba. So thanks very much indeed, Mark.
Thank you very much, Aziz. Very nice to be here. We have the first slide, please. Is that right? Thank you. Tiba is a Swahili word. It means to cure an infection. It's also the acronym for our NIHR Global Health Unit, tackling infections to benefit Africa. The most information, or most important information on this slide, is that our focus is neglected tropical diseases. But importantly, we're not just focusing on the usual model of one disease at a time. We're trying to treat these diseases within a wider context of co-infections, comorbidities, a social environment, a political environment, physical environment. We call this the African health ecosystem. Our partnership consists of the University of Edinburgh and 9 institutes from 9 sub-Saharan African countries, all leaders in infectious disease research in that part of the world. We also have linkages with some of the world-leading centres, research centres at the University of Edinburgh, including here at the Usher Institute, of course, but in several other fields as well. We have a very active programme of industry partners who are very engaged with some of our projects. And we're also engaging very closely with a number of national and international stakeholders, including the African Academy of Sciences, the African Union, and the World Health Organization. I'll talk a bit about that in a moment. The picture at the top left there is from our recent AGM in Durban, South Africa. You can see we're a large team, although not everyone there was able to come to that meeting at that time. What was very obvious to me at that meeting, and to everyone else who participated, was the tremendous enthusiasm and buy-in for what Tiba is trying to do. This was quite unprecedented in my experience. And we think there are a number of reasons for this, to do with the core principles by which we operate. The work in Tiba is Africa-led. We want African solutions for African problems. And that resonates very much with what Harry just said about people actually being asked what they want to do. That's our research comes from what our African partners want us to do. That is part of a process of shifting the centre of gravity to Africa, and as part of our commitment to that, we're trying to commit 80% of our £7 million funding from NIHR to our African institutions. We'll spend a very small amount of it, as small as we can, here in Edinburgh. And that is part of having truly equitable partnerships, both north-south partnerships between Edinburgh and our partners, but also among our partners and our other collaborators and people involved. And all that feeds into our philosophy of inclusive engagement. Our motto is, we leave no one behind. And that includes everybody in our partnership, but of course all the communities that we're trying to help as well through the work we do as part of this program. We're new, we're only a year old, so we're only just beginning to generate some of the outputs from our research programs. We've got about 15 funded research projects at the moment, several more, about the same number again to come. I'll highlight just one of these. This is a study coming out in BMJ Global Health next month on autoimmune disease, SLE. And the pictures there of SLE in black African patients. You won't find many pictures like that. SLE is a common and important problem, but most of the diagnostics have been developed for Caucasian populations in high-income countries. This is a study done in Zimbabwe of patients in Zimbabwe. And what we uncovered is, though a minority of these patients do fit the standard definitions, there is a large group that don't. Their autoreactivity profile and their clinical presentations are significantly different. They would not easily be picked up by the standard diagnostic procedures. So we feel we've uncovered a health inequity here. This is exactly the sort of thing that Tiba is trying to address. And again, it's an African-led project. Our capacity building program is very active. These are some of our 22 postgraduate research students doing a number of projects across all our partners. The important thing about our research students is these are based in and registered at African institutions. They're in African universities, because we want to move the centre of gravity for capacity building to Africa as well. We want to enhance that. The same thing applies to our workshops. This is a workshop we held earlier this year on research ethics, very well attended, very successful. It was held in Harare. It was led by the director of the Medical Research Council of Zimbabwe in that country. We're planning another workshop later this year, number 2. This will be held in Accra in Ghana. This is on real-time sequencing technologies, and this is explicitly to try and give our partners greater access to real-time sequencing for epidemic preparedness, things like Ebola outbreaks. There's a lot of interest among our partners in actually having that capacity in their labs, in their countries, and not having to import it in times of emergency. Our program of engagement covers a number of different levels. In the bottom left, you can see some of the community engagement. Tiba Tanzania, training community drug distributors. That's part of their program to try and eliminate lymphatic filariasis from Tanzania. Top left is Tiba Ghana. They're involved with their Ministry of Health, trying to eliminate malaria, or certainly control malaria in that country. We'd also have broader international engagement, beg your pardon, shown here. This is the 68th session of WHO oh, sorry, I'm on the wrong side. This is our involvement with African Union, NEPAD, the technical wing of the African Union. We've been helping them draft a research for health innovation strategy for Africa. We both helped them draft it, but Tiba is actually also mentioned in that continent-wide strategy as a model for possible research partnerships in the future. We're also involved with WHO Afro, the regional arm of WHO in Africa. And we've been specifically helping them with their National Health Systems Research Barometer. So a report on this came out earlier this year. It's a situational analysis of a number of sub-Saharan African countries, identifying where they have strengths and weaknesses in their health systems research. This work was presented at the 68th regional meeting of WHO Afro, which was held in Senegal last week. It's attended by every single Minister of Health in Africa, so this is a very, very high-profile meeting. That's the Tiba delegation preparing to present our report. That's the 68th meeting. In 2 years' time, there'll be the 69th meeting. We hope to go back to them with an update of the barometer, reporting on progress, and importantly, in those 2 years, we are going to be able to facilitate some of the activities that these countries will need in order to strengthen their health systems research capacity. So we'll report on that in 2 years' time. Finally, a few comments about the future. First of all, this substantial funding, £7 million from NIHR, has given us a unique opportunity. We can do things with this grant because of its scale and flexibility that simply were not possible in the research environment before. And Chris, I say this even when you're not in the room. It's a very real opportunity. We need to deliver on it, and we intend to do that. We would like Tiba to be sustainable. There is enormous enthusiasm and buy-in for this partnership, as I mentioned before. There's enormous enthusiasm for growing. We have many countries, many institutes in Africa who want to join the Tiba partnership that we cannot accommodate at the moment. We need to grow. We need additional resources to do that in the medium term. I have to say the Senegal meeting did not help there. There was a lot of enthusiasm for Tiba coming out of that meeting last week, so many more countries wanting to join. Finally, I should stress this is a real team effort. It's a huge team across many different countries. We all have our roles to play. Just a few key individuals. One of our deputy directors here, Moses Chimbari from University of KwaZulu-Natal. The gentleman in red is Professor Felix Decora. He's president of the African Academy of Sciences. He's on our external advisory group. The African Academy has been incredibly supportive to us, and Tom Kariuki, who many of you will know as their Director of Research and Training, is giving a guest lecture on behalf of Tiba here in Edinburgh in November. In the middle, we have Professor Francisco Matapi, the other co-deputy director of Tiba, who unfortunately can't be here today, and myself. But thank you to all of those people and everyone involved in the Tiba partnership. This is a real team effort. Thank you very much.
Thanks very much indeed, Mark. It's fantastic to see Tiba getting off to such a flying start. So we're a very interdisciplinary group in the Usher, and so it was a real pleasure to welcome Ewan Harrison into the Usher recently. Ewan is Senior Lecturer in General Surgery and is also part of a leadership team for global surgery, which he's going to tell us about. Thanks very much indeed, Ewan.
Of the 7 billion people in the world today, 5 billion of them don't have access to safe, effective and timely surgery. And of the 51 million deaths worldwide in 2012, 17 million of them were from deaths. Some of the deaths were from diseases typically requiring surgical care, compared with 3.8 million deaths from malaria, TB and HIV/AIDS combined. And while there are 300 million surgical procedures performed around the world each year, only 6% of those occur in the poorest 1/3 of the population. And we've estimated a shortfall of 140 million surgical procedures worldwide each year. So it's on that background that the NIHR Global Health Research Unit on Global Surgery has been formed, and the aim is to provide a platform providing clinical prioritisation, which is led within low and middle income countries, to provide research which changes practice, together to strengthen surgical systems worldwide. And we're doing that by establishing surgical research hubs that are autonomous, that are independent within low and middle income countries. The University of Edinburgh leads the data science and training, and our partners in the universities of Birmingham and Warwick lead on the trials and health services delivery. This has all been built on the Global Surge Collaborative, a wider group of 5,000 surgeons across 500 units in 100 countries who contribute to prospective surgical research worldwide. And this has allowed us to establish the NIHR unit within this grouping, focusing on countries that we've got long-term, sustained, deep relationships with. By empowering grassroots surgeons to collect prospective data, we can collect and generate data at scale. 12,500 patients in this recent study looking at surgical site infection across 350 hospitals in 66 countries. And we not only showed a higher rate of surgical site infection in resource-poor areas around the world, but a higher rate of antimicrobial resistance in those patients. And this received great global impact when it was published earlier in the year, was reported in the popular press in 22 countries, and is in the top 10 of Lancet infectious disease papers as per the Altmetrics scoring system. So we've got hubs set up in Mexico, Ghana, South Africa, Rwanda, and India, with the Pakistan hub coming close behind, and further opportunities in the Philippines, Nigeria, and Peru. We run research cycles throughout the course of the grant. Low and middle income country led research prioritization feeds into patient level observational data collection, which informs interventional trial design, and at the same time there's early engagement with ministries around implementation and policy. We had our launch meeting in Johannesburg last year, which was the culmination of a research prioritization process, which highlighted access to surgical care, perioperative surgical care, and cancer as the three initial work streams that we're going to focus on. And we've got programs now running under each of these three themes. Just to give you a flavour, this is our first multinational randomised controlled trial, which will run across hub countries. It's looking at two simple measures to reduce surgical site infection after gastrointestinal surgery, 6,000 patients, 40 centres, and we've got a grant application in at the moment for the follow-up cluster randomised controlled trial, which you may hear a bit more in the future. In the cancer work stream, our global cohort study is running at the moment across countries of all income levels. 90 countries signed up to look at quality and outcomes after breast, gastric, and colon cancer. And our hub countries allow us to look in more detail with, for instance, feasibility studies around long-term data collection on cancer outcomes in low and middle income countries. We have a further grant in around the follow-up trial for that, a cluster randomised controlled trial of a nutritional intervention, which we've been piloting around the time of cancer surgery. Training is important. As we've heard earlier today, we clearly provide project-specific training, but we also try to, without sounding too mawkish, train the next generation of surgeon scientists in low and middle income countries. So using our master's programme, which is by distance learning, which we run from the University of Edinburgh, we're pleased to say that we've already got 12 master students who are young surgeons within our hub countries being indoctrinated as to the benefits of research within surgery. These projects are complex and they require really good organisation. Our hubs are front and centre of that, with clear interactions with the UK HEIs. We receive independent advice from an external advisory board, which feeds into a global surgery policy consortium with close links with the WHO, industry, and global policy advocacy groups in surgery. And the key message is similar to what the two speakers before me have said. It's to shift the ownership of the global surgery research agenda to low and middle income country surgeons working with their country, and for UK groups to simply be collaborators as part of that. It's been an exciting journey, working with fantastic people like our Rwandan group here, some of who have recently visited Edinburgh. Many thanks for the opportunity to speak today.
Thanks very much indeed, Ewan. And the scale of in this initiative is absolutely phenomenal. So please do go away and have a look at some more details about that. So next up, we've got Harish Nair. Harish is Chair of Paediatric Infectious Diseases and Global Health, and is also leading Rescue, which is going to speak about. So thanks very much indeed, Harish.
Thank you, Aziz. So before I start with rescue, I think it's important to acquaint everyone with RSV and the efforts to develop an RSV vaccine. So human RSV is an RNA virus, and it is quite ubiquitous. Almost all the children by the age of 4 years get infected by this virus. It's known to cause severe disease at the extremes of age spectrum and in those with comorbidities. So we've published the RSV disease burden estimates. The most recent one was published last year, and we estimate that globally there are about 33 million episodes of RSV-associated acute lower respiratory infections, including pneumonia and bronchiolitis in children under the age of 5 years. 10% of these require hospitalizations, and there are between 60,000 to 120,000 deaths worldwide in children under the age of 5. And the disease burden is disproportionately higher in children younger than 6 months. The other age group that gets infected by RSV and there's a high disease burden is the elderly aged above 65 years of age. And data from many high-income countries, including Canada and the UK, show that the RSV disease burden, particularly in terms of hospitalization, is comparable to influenza, particularly the data you see from the UK. And in terms of deaths as well, it's comparable. In terms of GP hospitalizations, at least in the UK, studies have shown that there are more GP consultations in the elderly from the RSV compared to influenza. So if the disease burden is such high, then why don't we have an RSV vaccine? Well, there was an effort to develop RSV vaccine in the early 60s. A formalin inactivated vaccine was developed, and that was administered to infants. However, there was enhanced respiratory disease in the vaccine arm, and there were 2 deaths as well in the children who were vaccinated. So after the failure of this particular vaccine, all efforts to develop another RSV vaccine was abandoned. And it was not until 2010 when we first published the first RSV disease burden estimates and highlighted the scale of the problem that agencies like the Gates Foundation and WHO picked this up. And now we've got numerous, more than 40 candidate vaccines in the pipeline, and ranging from live attenuated vaccines to particle-based vaccines to subunit vaccines, etc. And we have a vaccine now in phase 3, which is a maternal vaccine, and we've also got 6 vaccines in phase 2, 3 in the elderly, 3 in the pediatric age group. So it's very likely that in the next 5 years we will have 1 or more RSV vaccine that would become available for licensure. So it's against this background that the Innovative Medicines Initiative funded us to build an evidence base on RSV disease burden and associated economic impact for Europe, particularly to inform vaccine policy and for clinical case management, and build a pan-European stakeholder community for RSV. We also aim to develop a powerful biorepository for future research and collaborate with regulatory agencies, the EMA and the FDA, and establish an ethics and governance framework that would allow the academia and the public health agencies to work constructively with the pharmaceutical industry. So the consortium itself, 18 partners, 6 from the pharmaceutical industry and 12 from the public consortium, and the consortium is led by the University of Edinburgh. So in this consortium, we have the rescue core, which is the 18 partners, but we have more than 40 partners who do not receive rescue funding or the European Commission funding, but are actively engaged in the rescue work. So they are the affiliate partners, and we have both EU and non-EU affiliate partners. So the bulk of the affiliate partners you see here are from the EU, but we have partners from North and South America and also from Australia. In terms of project structure, we've got 5 technical work packages that are linked to each other. So there's a work package on systematic literature review. There's another work package looking at linked data analysis in 7 European countries. There's a work package looking at health economic analysis. There's a work package looking at initiating prospective studies to understand disease burden in the infants, in the elderly, and in adults with comorbidities. There's a work package looking at understanding the biomarkers for severe disease and poor outcomes. And all these work packages are supported by a project management work package, and we've got 3 independent advisory groups. We have an international scientific advisory group, we have a patient advisory board, and we have an ethics advisory committee. Edinburgh leads 2 of the 5 work packages. And then we take patient involvement very seriously. In the inaugural meeting, we had this inspiring talk on putting the patient interest first. We have a very active rescue website. We have a quarterly newsletter that's sent to all the stakeholders. We plan to have RSV Science Policy Forum in the final year of rescue to engage more widely with policymakers. We plan to have a session at the annual health forum in Gastein. And over the course of the rescue, we plan to have an RSV observatory as well. So this is a photograph from the kickoff meeting in Barcelona, which was in January last year. And this year in June, we had our second annual General Assembly meeting in Oxford. Thank you.
Thanks very much, Harish. So it's difficult to summarise sort of 29 million euros of investment in 7 minutes, but yeah, very well done indeed. And so last, but certainly not least, we have Devi Sridhar. Devi's our Chair of Global Public Health and is a real expert on global health governance, and that's really a key underpinning issue that spans across our global health work. So Devi, thanks very much indeed.
Thanks very much, Aziz. I'm very aware that I'm here after you've been sitting through 7 talks, and I'm also standing not only between you and coffee, but between you, coffee, Chris Whitty, and the principal, which it makes it even more fun slot to have. So I thought I would start my lecture here, talk about theories of regulation, history of international cooperation in health, and then I just imagined your eyes glazing over and just hopefully waking up when it was coffee time. So instead, I'm just going to go straight into who we are and what do we do and why we think it matters. So we look at how global health is governed. So how do you actually look at that? You look at global institutions, finance, and rules. So institutions are like the World Health Organization, the World Bank, but also big partnerships, even projects like Harish was talking about, where you have private sector involved with public institutions. We also look at money. Where does it come from and where does it go? A lot of questions can be answered if you just track the money. One of the hardest things to do, actually, is actually track a grant from where it starts all the way down to where the money is actually spent. Finally, we looked at rules. How do we actually get things done as a global community? We need agreements. How are these agreements created? Are they binding? Are they just normative, that we kind of all think it's a good idea? And the whole range of those. And so this is our team. As social scientists, we're very dependent on fantastic individual researchers. Usually this kind of work is done in isolation. Scholars write books. Individuals have, their own teaching program. So we are actually currently the largest group in the world working on this area. We have a group from all areas: historians, medical anthropologists, economic anthropologists, public health practitioners, and political scientists. Over the past 4 years since we've been started, our team has been PI or co-I in over £17 million in grants. In terms of our partnerships, this is the range of countries that our team is working within. And what I would do, I thought, instead of giving a large overview of everyone, is actually pick out some of the key people and the key projects that we're working on, and perhaps show you why this kind of work, while very time-intensive, is incredibly important to get to the heart of why do things actually happen in global health. So first, we can highlight Marley Tishanor. So Marley's a medical anthropologist who spent 14 months in Senegal during her PhD, and then joined us here and has spent the past year between Senegal, Washington, D.C., and Seattle. And what she's trying to understand is the relationship between the Bill and Melinda Gates Foundation, the Institute for Health Metrics and Evaluation, which produces data and is funded by the Gates Foundation, the World Bank, which is doing a human capital project, which ties into those two, and actually what does it mean for the Ministry of Health and those working towards universal health coverage in Seattle? What's the role of metrics and numbers connecting those? And what does this tell us of how they're produced and who actually consumes that data? I can highlight Felix, who always makes me nervous. Just this morning he posted a tweet of a protest he was observing in Haiti. He spent the last year living in Haiti and describes a dual economy where he's not part of either, because he's not part of the wealthy expat community that comes in and out, and he's not obviously Haitian and living there. And so use this to actually understand, how do you do infectious disease control in failed states? In states where there's no functioning government, and every day there's basically each for their own. And so this is pictures of him water, and that's what we're getting to the heart of, that actually from living there he realizes that actually water contamination is one of the drivers, and actually if you have to carry water everywhere you go, this is him carrying it, and he's actually joined a team doing decontamination of houses for cholera, which makes me very nervous as his line manager, but he seems to want to do it and says it's incredibly informative. And then we have Genevieve. She wants to look at, actually, we've talked today about partnerships, but how does this usually happen? How do you have external donors come into countries? What are the tools for accountability and sustainability? So she's been spending, again, over the course of the year between India and Washington, D.C., trying to understand maternal, newborn, and child health, and what actually can we develop in terms of a framework for understanding when external actors, whether it's the World Bank or the WHO or the UK government, go into countries, how can we understand how influence works if we say we want to influence something in a country? And finally, I wanted to highlight Janelle, because she's a historian, so she's been actually in the archives of DC, and I don't know if she's here today. No, I don't see her. She's often in the archives, as historians are, and in also the UN, in the FAO, in the World Bank. And what she wants to get an idea of is, why do we call things successes? We often say in global health, that program was so successful, or that was so successful. So she's trying to track back these successes to how is success actually defined? Is there an agreed definition? And actually, can we apply it to different case studies to find a framework that we can use beyond saying one thing is a success, to actually saying, how can we actually measure success overall? And I have to highlight Lorna Thompson, because in the end, research is very dependent on having very strong research managers and administrative support. And she leads in our public engagement. For example, we're going to be doing work with the Science Festival, and including students from around Edinburgh through the Widening Participation Initiative. She does all of our outreach, our communications, but also ensures we're attentive to diversity, equality, and inclusion. It's really important for us that we actually are attentive to that. We need to have diversity in the room when we're doing these kind of projects, in backgrounds and experience and disciplines, as well as in gender. So finally, coming to some of our outputs if you're interested in learning more. So we have a B&J series. Jim Kim won't be happy with that picture, so don't tweet it because his face is cut off in half. So the World Bank and financing global health, we had a series on this, a series of articles. We have a second series coming out this year called, with the B&J, called Health, Economics, and Profit. How do you reconcile profit with improving public health? We are the first collection with Welcome Open Research, the World Bank and Global Public Health, and have a number of articles. This is Wellcome Trust's way of actually trying to shift the publishing model towards one which is open, one which is available. And we have a number of articles going up with open peer review. You can see the whole process unfolding. We also have a YouTube channel, and our channel on the World Bank and Global Health, our video specifically, has almost got 17,000 views, which if you know how many people are interested in the bank and global health, this has gone viral in our world. And finally, we continually are putting up blogs. This is for us to become a hub and actually try to influence conversations and policymakers. This is just our latest 3 blogs, which are about counting births and deaths, formula sales, and that was about Donald Trump's comment about breastfeeding, and supporting new and diverse voices in global health. And I guess the overall objective of our program is really to improve people's health worldwide. But if you want to improve people's health worldwide, if you want to reach things like the Sustainable Development Goals, then you actually have to understand the architecture, the system, the incentives, the financing, and that's what the researchers in our program aim to do. So I'll end there. Thank you.
So thanks very much indeed, Debbie. Fantastic. So can I just ask all of our speakers to come and take a seat at the front? And this is the, I mean, I know we've been speaking at you, but hopefully this is an opportunity now for you to raise any comments or questions or thoughts that you have. Who'd like to get the ball rolling? Linda. So if you wouldn't mind just introducing yourself, Linda. Linda's, let me introduce Linda. Sure. Linda is our new, soon-to-be in post, I think in 3 weeks' time, a new Bruce and Usher Chair of Public Health taking over from Raj Gopal. So Linda, we're delighted to have you as part of the Usher family.
Thanks. So that was a very impressive array of presentations and overviews on the grants and the work that's been built on decades of previous work. I wonder to what extent there's an opportunity to try and capture some of the information and the experience that you're building around the processes that many of you are undertaking across these projects at Edinburgh with partners. And I'm thinking particularly of things like stakeholder engagement and how when you have come up with a new finding or a discovery, how that can be implemented, which I think is dependent on having those stakeholders in the room from the beginning. So I just wondered whether you had any thoughts on that and whether there might be publications, for example, that might emerge from that type of learning.
Thank you very much. We actually have a whole work package on exactly that question. So I mentioned at the end of my presentation that I thought this particular call, the NIHR Global Health Units, provided us all, not just Tiba, with unique opportunities. And one of those opportunities is not to be doing worthy but small projects in isolation, but to do them as a team, to learn from them as a team, to ask the exact questions that you were just asking, and study them. We call it the toolkit projects, the meta projects, the ones that will learn from both our successes, and I think this is crucial, from our failures, because those are often just as informative. And they're also, incidentally, a vehicle for South-South learning, because the range of health systems that we're engaged with, they range from South Africa to Sudan. There are plenty of problems and solutions where the meaningful exchanges between those two countries are not necessarily involved in the UK. So I absolutely agree with you, and yes, we're doing it.
Tiba, did you want to add? Thanks for that question too. So one of these tools that we've developed for setting priorities, particularly research priorities, the Chunri tool, has been announced in 2007, and now by the recent reviews, it's really pushed out all the other methods, and it's been implemented more than 100 times, but in a big way. For example, in India, there were 4,000 people and 160 medical schools taking part in national level research prioritization recently, or UNAIDS has done it for UN. So now we had 10 years later examples from 100 cases of implementation. But when you do research priority setting, you don't want to just publish a paper and nothing happening. So over the 10 years, we've evolved approaches towards engagement of stakeholders, and we have published in 2016 a series of 10 papers reflecting on those 100 cases of implementation in all sorts of contexts, all sorts of national level, global level, regional level, every imaginable topic that we addressed, and how did we engage stakeholders, and also what was the impact of these exercises later. So I think we had a great opportunity for implementing this tool to really work with stakeholders and understand how to bring them on board. One important thing is you have to bring them on board from the start. You have to give them buy-in very early in the process. Otherwise, it's very difficult once you've launched it to explain to them what you're doing and then bring them on board later. So that's probably the most important finding that we have. But there is a paper on this, quite a long one, and it's in Journal of Global Health 2016.
Okay, and Lawrence, maybe.
Yeah, I think that in the case of the Shell study, for instance, when it started off, Raj and his colleagues were discussing how they would link the census with health data, and this never been done before. And Raj has often said, when they first talked about it, well, the chances are we'll end up in prison about this because it's considered a completely illegal thing to do. But they showed that with a great deal of thought, with persistence about tackling the ethical issues, the issues of anonymity, issues of consent or non-consent, they were able to come up with a method that satisfied at least the authorities. And then we took that a bit further by setting up a public panel with just under 20 people from different ethnic backgrounds in Scotland, a wide range of other professional and other backgrounds, to find out what they thought of this type of way of using public data. Were they happy that it represented something that was safe? Did they feel that it was going to be potentially misused? That's been written up in a Journal of Public Health article. But one of the things that they pointed out was, we need to know more about this stuff. Why haven't we heard about this before? And it does emphasize that there is a need and an appetite for people in the general public to hear about the type of work, fantastic work we've been hearing about this afternoon, and get more of a sense of what it actually means to them in their daily lives.
Is this a microphone? Good grief. Right. Richard Weller, I'm a dermatologist. I work in Ethiopia each year as well, in a leprosy hospital out there. Is the rise of nationalism in the rich world going to affect, I suppose, these supranational global health, common goods for the general people? Is that going to be affected by the rise of nationalism in the rich world?
I'll take it on. I mean, I think these perturbations in global political systems shouldn't be kind of overread in the short term. And what you are rightly reading into these kind of popular movements which are prominent in North America and Europe at the moment of nationalism, we don't know whether this is a fundamental change in the attitudes of humanity. And we were sitting with Chris Whitty this morning talking about the UK's great contribution to overseas development aid, and that there's no particular concern that that is going to decrease over the next 10 or 15 years. So I do not think that the column inches which is being devoted to nationalism at the moment will change a basic drive of humanity, which is to help people.
So you want to chuck it across as well.
Okay.
Oh, I can throw something at Jonathan.
Everybody wants to.
Oh.
So that was brilliant. That was absolutely extraordinary what you're able to do. So how is the university investing an obscene amount of money into a new Usher Institute going to make it even better?
That's for Aziz. That's for Aziz, yes.
I've got two mics here. So, I mean, I think we're in this incredibly fortunate position that we have a thriving group, fantastic leadership across the Usher Institute. So we're something like 320 academics and professional staff, 100 or so PhD students, 350 master's students. So grown phenomenally. I think there's something like 30 posts open at the moment. So if you're interested, you're not part of the Usher at the moment, do have a look at those. What Jonathan's alluding to is, as a result of the city deal, which I mentioned, we are going to have something like £65 million being invested in a new building. That for us is strategically really important, because at the moment we are across 5 sites. So these kind of events where we come together as an Usher Institute are really important, and co-locating, I think, will be incredibly helpful. What we're trying to do in this global health area is begin to really synergize this effort, because you can see so much opportunities for cross-learning, for cross-sharing of ideas. Respire, for example, is currently in South Asia. There's clearly a possible extension into Africa, for example, the work that Mark was describing in Tiba and vice versa. So those synergies. The other big issue for us is, how can we really embed data science capabilities to underpin everything that we do? Because so much of the time we are investing public money, and this is once off. What we need to do is get this whole area onto the front foot, so we are actually generating these data and using them repeatedly for public good. These data only add they grow in value once we can begin to link these data and grow the kind of human capabilities to exploit these data. So I think, Jonathan, my feeling is we are just beginning. We're very, very new, but I think the opportunities for us are absolutely phenomenal going forward. I don't know if anybody wants to pick up on that. Liz or Harry maybe. Oh, Debbie's got her hand up there.
Sure. And just one other thing. I think one of the things you've heard from all of us is that as the centre of gravity shifts in a sense to really support universities in the global south to become the leaders of tomorrow, I think that's one of the things that Usher is completely committed to do, is about widening access and ensuring the faculty who we are partnering with become leaders. And I hope that that will be the investment in Usher that will then become a global investment.
So I actually wanted to answer the previous question on nationalism, if that's okay. Because I think if you ask the question, is Donald Trump good for global health? The answer is clearly no. Is Brexit good for global health? The answer is clearly no. And I can give you just 3 tangible examples. So first, on universal health coverage, that everyone is covered, has access to health services without impoverishment. We're lucky and we have the NHS. We might have our grumbles about the NHS, it has major problems, but the fundamentals remain there. And generally the public agrees on those fundamentals. We don't have that in the States. And actually now, for leaders like Dr. Tedros of the WHO, if he wants to go and promote a UHC agenda, universal health coverage agenda, he does not have the US behind him on that. And that's actually a big blow to global health. Second example, antimicrobial resistance, or AMR. I'm getting into the world of acronyms. I'll try to stay clear of them. So as you know, it's a growing problem, superbugs, people are worried, and the focus has largely been on actual, human consumption. The NHS trying to get doctors to prescribe less. But a large part of the problem is actually coming from the agricultural sector and being used as growth promoters. And this is not happening as much in the EU because it's regulated. It's happening in the US, where it's still not regulated. It's happening in China. It's happening in Brazil, in India. And there you need global agreements. And to get global agreements, you need, when Sally Davies wants to champion this, our chief medical officer, that she actually has someone on the line she can call in the States who will have her back. And right now, the US, at least in these global agreements and forums, is pushing back against that. They don't want to have global standards for agricultural use. The third one I'll give is actually an infectious disease. Outbreaks. We're all worried about the next Ebola, the next viral, flu that's going to go have a high mortality rate and we won't have a treatment for. And actually, the US plays a huge role. If you look at the Ebola outbreak, how it was contained, the US carries a large share of that burden. Recently, the State Department closed that position. There's no one responsible now at the State Department in the States for global health security. So we can say, the scientists at least I think are aligned on where things are moving positively, but at least from the political viewpoint, and for people around the world, if you do believe, as Liz has said, that all people are equal regardless of your skin color, of your gender, of your sexual orientation, the world you're living in now is extremely scary. And I think it's just worth calling out that our role is actually to speak out against that and continually keep pushing. And Lorna, who's here, has written a brilliant blog where she goes through the tweet about Donald Trump put out a tweet. It's a tweet, but it's a Donald Trump tweet. So it does change markets and policies. And Donald Trump said in his tweet that actually, that pushing breastfeeding is bad because actually you're making women die. And she goes into a very evidence-based blog of actually why he's completely wrong and actually trying to shift actually the public to understanding why breastfeeding is life-saving intervention. And tweets like his are actually extremely detrimental to people's health around the world. So I feel quite strongly on this issue because I wanted to pick it up because we are in dangerous times and those who have a voice should use it today.
Thanks, Debbie. Raj, so could you just pass
Thank you. Firstly, I'm Raj Bhopal. I'm Emeritus Professor of Public Health. And this is so exciting, I'm tempted to apply for one of those 30 posts. I think every one of the panelists will think that sustainability is of the utmost importance. In my 30+ years of public health in the UK, I found that many great projects are not sustained, even in our very rich country. Even although we've evaluated them, we've shown their benefits, when the project ends, it ends because there's no budget. There's no budget holder with responsibility. It's one thing to bring people on board as participants in a project. It's another thing to get a project into the budget line of a foreign government's set of priorities. I was wondering if the panelists might like to make a comment as to how they might be trying to encourage that long-term sustainability through financial planning in the locality they're working in.
So I think one answer to this is following the principles that NIHR are championing here. And one of those principles is tackling problems that are locally identified and focusing on stakeholder engagement. So in Respire, 2 of the projects, for example, in Bangladesh, are looking at scaling up the use of pulse oximetry in identifying children that should be admitted to hospital. And I mentioned bubble CPAP as a way of a low-cost technology for the treatment of children with severe pneumonia being a major cause of child death in Bangladesh. So in both of those projects, we're holding a Ministry of Health workshop with the Ministry of Health right at the start of the project to discuss the project, to invite them to be part of this, to get their views on their interest in it and whether they think this is being conducted in the right way, because the sustainability of pulse oximetry and bubble CPAP should not be dependent on us getting another NIHR grant or another research grant. It revolves around whether the ministry is going to take this up or not. And it's not reasonable to expect the ministry to take this up if this is not one of the problems that the ministry identified is needing addressing in the first place, and you didn't involve them right at the start in deciding how you're going to address this problem. So I think a fundamental thing is right at the start to follow this equitable partnerships model that NIHR is championing.
Thank you.
And just following on from that, with the global palliative care example, from our research work, what was very clear was the need for concurrent work, concurrent work at the global level, with WHO getting palliative care into the as a resolution, concurrent work at national level, ministries requesting palliative care support, advice, modelling, concurrent at the district level for it to be in the budget lines, but concurrent also with the public engagement, with communities, with patients, with those who actually know what it's like, with faith communities. And the big lesson for me in all of this was we do things in stages and think that we can achieve, whereas things need to be done synchronously together and concurrently.
So from the rescue perspective, for sustainability, that's a key component of any of the IMI projects. The EU looks at it very seriously. And what we think is that we've been in discussions now between the partners on how we would like to take this forward, possibly at the end of the project, like as a spin-off company, because we'll be generating a whole lot of new resources. There'll be data that'll get generated. There'll be this biorepository that would be available. Again, that would be quite appealing to the pharmaceutical industries and also to researchers in general. And so there is the idea that we would open this up to the community, to the scientific community, and to the industry, and also the RSV observatory that I sort of alluded to in my presentation is something which is an aspect of sustainability. So by the end of the project, we should have this observatory up and running, and it will have access which would be paid. So some of the external people who were not part of the project itself could pay to access those data.
Yes, I'd like to thank you for the question, because you get a project of 7 million and you're phenomenally happy. And then once you realize you have 7 million for Bangladesh with 160 million people, and Pakistan with hundreds of millions, and India with 1 billion, and then Malaysia on the top, I mean, what can you really do? That money just disappears, yet it seems so big to us. And Aziz and I, even before the paperwork was signed on Respire, we went to the World Bank and said, look, there's a really serious effort now to support respiratory medicine agenda. And there's plenty of money for various other things in global health, but respiratory medicine has really been a neglected thing, and we have a chance to lead. How do you, once you get traction somewhere, how do you build on this, and how do you make it sustainable? And they taught us of a few words. So one is pilotitis. They say that the whole developing country world suffers from pilotitis because everyone gets the money to pilot something and they show it works. But then the word, how to get from knowing what to do to then spreading it and scaling it up. This is a really big conundrum for everyone. And then a second thing we learned is that you need to generate a thunderclap effect, apparently. So not just tackle it through research, but also penetrate in the media, penetrate in the company world, try to get everyone interested at the same time, use social media. So I took up after that a PhD student who is now building our capacity to do videos and to study how to make global health topics go viral online, so that we can actually try to address several things at the same time and just generate the buzz around an issue. Because when you look back into how things worked and gained traction, this is exactly the way. Someone managed to make something very interesting at some point in time, and there was a buzz generated, and you reach a tipping point. There's even a lovely book by Malcolm Gladwell about it, and then things take on, and others don't. There's nothing rational about it. It's just you have to generate this kind of tipping point, and that's what we need to think how to do.
Great. Okay. So, I mean, I remember from that meeting at the World Bank, their idea of pilots was $500 million each year. So hence, Devi's work is incredibly important. So we're at 2:30. So just like to, before we break for coffee, just thank our speakers. Done a fantastic job in summarising so much work that's going on in such a limited time. So thanks very much indeed. Thank you. So welcome back. Great to see this conversation taking place over coffee, and thanks again to those fantastic overview presentations just before coffee. So now we get to, the main reason why we're here today, our third Usher annual lecture. And it's a great privilege to welcome Peter Mathieson, our newly appointed principal, who's completely passionate about global health, to introduce Chris Whitty. So, Peter, thanks very much indeed for coming along, and really looking forward to hear what you could say. Thank you.
Aziz. Thank you. Thanks very much, Aziz. Yes, as Aziz says, I used to be a doctor once, and I used to dabble in global health, particularly in sub-Saharan Africa. So I am very interested in it, although I made a terrible mistake a few years ago and started becoming an administrator, and it's a slippery slope that I advise all of you not to get on. But anyway, for today, it's a great pleasure to welcome you to the third annual Usher lecture. I'm sorry that I couldn't be here for the preceding session because it sounded terrific, but I'm sure Aziz and others will fill me in on all the details of what's going on. I just want to introduce to you our speaker. So Professor Chris Whitty, many of you will know, a clinical epidemiologist by background, with a great deal of experience in both Africa and Asia. Currently, let me get the title right, Chief Scientific Advisor for the UK Government's Department of Health and Social Care, with overall responsibility for scientific advice for policy and the Department's research and development, including the National Institute for Health Research. So he's important. And the National Institute for Health Research is important to us, even though we're in Scotland. Please take that message back with you, and that we don't want them to forget that Scotland exists as well. Chris is Professor of Public and International Health at the London School of Hygiene and Tropical Medicine, a consultant physician in acute medicine and infectious diseases at University College London Hospitals and the Hospital for Tropical Diseases, and Gresham Professor of Physics at Gresham College. So over to you, Chris. We're very interested to hear from you, and we're very interested, I hope you'll take some questions at the end, but I'm sure you'll stimulate some further discussion from this audience. Thank you very much, and welcome to Edinburgh.
Thank you.
Thank you very much for inviting me, and those were absolutely terrific talks earlier, and it's been extremely interesting talking to people in front of their posters. The amount of work that's going on here globally is extraordinary, really, and clearly accelerating. I'm aware of the fact I'm talking to a mixed audience, and therefore what I'm going to do is not concentrate on one particular area. I'm going to take the privilege of someone who dabbles in lots of things and is an expert any longer in none of them, to do a very, very broad overview. And in particular, what I'm going to do is I'm going to project forward in some areas I think are important over the next 20 years. Now, I'm aware that a lot of people think projection forward is extremely difficult. I don't actually agree with that. My general view is, provided you can use a ruler and follow a trend line that's been followed for the last 40 years, you're probably in pretty safe base. And the big pitfalls, to be honest, of forward projections are optimism bias, pessimism bias, and the usual enthusiasm for anecdote trumping data. Most clinical researchers I know combine optimism bias and pessimism bias simultaneously. So, for example, most of my colleagues believe simultaneously that the NHS is about to collapse, which they've been believing their entire careers, and that their own research is going to transform the world. Those probably both need to be modified. So in this Usher Institute lecture, I'm going to consider 4 areas. Two areas which I think are, with some caveats which I'll come back to, unalloyed goods, things going in absolutely the right direction, but with some difficulties, which are the change in global mortality patterns which have followed from the assault on infectious diseases. Secondly, the changes in fertility, which have led to really profound demographic shifts, which can have very big implications for medicine more generally. But then I'm going to move to 2 where I think our report card, when future generations look at us, is going to be seen as much more mixed. Cardiovascular disease, where things are going stunningly well in higher income countries and stunningly not well in low and middle income countries for reasons I'll come on to, and cancer, where I think the jury is still out. And then I'm going to talk, throughout this, I'm going to think about what can we do in a resource-constrained environment. Most of what I'm going to do is present data. I'm also going to present, and I'll try and flag this, a few of my own opinions. Please feel free to disagree with the opinions in questions or afterwards. Let's start off with some just broad deaths in absolute numbers globally. This slide is probably the most encouraging thing you probably should see in the rest of your clinical lifetimes. This is the change in child mortality that has been since 1970 on the left of this slide as you look at it. And this change with a corresponding shift upwards in age is accelerating. So if you look at the under 5 child mortality between a lot of areas still left behind, and I'd like to highlight at the bottom what I've done is done some absolute numbers, compare the middle income countries to the UK, which is currently pretty average for a high income country, and just comparing Nigeria to its near neighbour in West Africa, Ghana, makes it clear there's a lot still to do. Now this of course has not happened in just one number of incremental advances, all of which, if you did an attributable fraction, would probably be 1 or 2%. But this is hundreds of 1 or 2% changes the ratios varying, stacked on top of one another in different countries, rather than one or two big changes you can get your arms around. And just to take two of the most important diseases, we've heard earlier on about RSV. I'm going to take a different disease, which is a vaccine-preventable disease now, which is rotavirus. This is one of the leading causes of diarrheal disease. And there has been a steady reduction in rotavirus deaths globally, initially due to old-fashioned improvements in sanitation and hygiene that would have been recognizable to public health physicians 100 years ago, but more recently to rotavirus vaccine, which is having really quite a substantial impact and is going to continue to do so. And that's important because over 28% of all the deaths, diarrheal deaths in children this age, are attributed to rotavirus at the moment. This ratio, of course, is now dropping. So rotavirus, just to take just the vaccine, one technology, has averted probably over 28,000 deaths in 2016, the last year for which we have full data. So sometimes it's based on particular technologies, of course, backed up by development. And I put at the top of this slide a large number of other diseases where a technology, a vaccine technology, has had a massive impact. Tetanus, diphtheria, polio, pneumococcus, measles in particular. Another group of diseases which, again, have had multiple impacts from lots of different interventions are the vector-borne diseases. And of these, for children, the most important globally is malaria, a disease I've had the privilege to work on before I became an administrator, as the principal puts it. And if you look at malaria mortality rates, this is a huge cause of mortality. When I started in malaria, we would start every talk with a statement that over 1 million children a year had died of malaria. That was in 2000. Since that time, mortality rates have fallen by 69% in children under the age of 5%. Just think about that in the time span we're talking about. This is a really pretty small time span, with around 7 million malaria deaths averted in African children. And it's likely now to shift from being an endemic disease that all children get repeatedly in childhood, and it follows the same pattern every year, to an epidemic disease which actually affects very few children in any given year, and then there'll be sudden epidemics that will affect the whole population. This shift, I think people are not yet ready for, but this is the absolutely inevitable epidemiological result of this change. So we do need to think through that our success breeds with it new problems that we need to think ahead for and head off. Now, if you just think about malaria, I've just listed here a small number of the different sciences that were essential to tackling this one disease. And many of them are ones that we would not normally think of as medical, including things like pesticides, engineering, and economics, all of which are absolutely essential to this. So if you want to take a serious swing at a serious disease, you're going to have to use very many sciences and pull them together in a coherent way. And this is the kind of thing which we were hearing in the excellent talks before coffee that you're doing here in Edinburgh and needs to be done across the UK with our partners in Africa, Asia and Latin America. So the second general point I'd make is it's very many interventions from very many sciences that stack up to cause very large changes. And that is what we've seen happen over the last 15 years. The result of this is that we're seeing a shift increasingly in global child mortality to a situation where the majority of child deaths are in the first 28 days of life. And I would predict that in the next 20 years, virtually everywhere in the world, most children who die will die so before their 28th day. So childhood disease, a remarkable achievement, and the achievements in terms of the changes in infectious diseases have extended also to adult disease. For example, here are the 3 diseases, infectious diseases, I would least like to die from, having watched other people die from them. They are horrible diseases. Human African trypanosomiasis, where people essentially get very rapidly demented. Rabies, die in absolute terror. It's a horrible disease to watch. And tetanus, where you die in extreme pain. Each one of these diseases, and very many others, these are all neurological diseases, it happens, very substantial reductions recently. So not only have you got the diseases of of childhood going down very rapidly, you've also got the infectious diseases of young adults going down very rapidly. The biggest of them all, clearly, is HIV. Prevalence of HIV is dropping rather depressingly slowly, but actually that's partially a good thing. It's partially because people who have HIV are now living the majority, at least, of their adult lives. I think it's too early to say if they're living the majority of their older years. And what we've seen is, over the last decade, a really remarkable reduction in mortality from HIV due to treatment. So incident rates are going down, but the really big shift has been reductions in mortality. So, you know, that, if I stopped the lecture there, you'd think that everything was absolutely terrific on infectious diseases, so let me add in a few caveats. There are very many pitfalls in infectious diseases over the next 2 decades, some of which are very well known. So we all know that antimicrobial resistance is a great and growing problem across bacteria, viruses, and parasites. Fungi as well, actually, if it happens. We know that there is a significant risk for several of the vaccines that we're going to see an evolutionary response where the infections will essentially evolve around the vaccines that we produce. And I was discussing one of your colleagues earlier on about RSV, and that this is a significant risk looking to the future. But I'd like to highlight a few others which I think are rather less well known. There are several infections which are specific to urbanization. I'll just show some data on this. Several I think there's already global overreach in terms of claiming we can eradicate and eliminate diseases, and for reasons I'll come on to, that is politically very problematic. Several endemic diseases are going to become epidemic, and we're not yet ready to deal with them as massive epidemics affecting all age groups. And of course there are going to be still major epidemics from diseases that we know, old friends like influenza, diseases that emerge like Ebola, which caused such chaos and tragic mortality in West Africa 3 years ago, and diseases we don't know about, which will emerge and have emerged all the way through history. And finally, a point which I would like to come back to at the end, I think that infectious disease doctors and scientists have been far too slow to think about secondary prevention in the way that cardiovascular doctors have done now for several decades. And I think that is going to cause us significant problems as the infectious diseases concentrate in a smaller and smaller group of people. So let's just back up those points with data on the ones that are less well known. Infectious diseases of urbanization. Several infectious diseases are much easier to transmit in an urban environment. I've just chosen a vector-borne disease here, dengue. This is the spread of dengue through the Americas over time. This is because the vector for this, Aedes mosquitoes, is ideally suited to peri-urban life. The more slums you get, the more dengue you're going to get, and with this go the other diseases that go with Aedes, Zika, big outbreaks recently, yellow fever, for example, several other diseases which are going to increase just because we've created an ecological niche that is perfect for particular infections. Alongside that, diseases of crowding, several of the respiratory diseases, and diseases of poor sanitation, like typhoid, for example. Increasing typhoid in Africa used to actually not to be a very major problem, despite what you're told when you go out there and get fever, but that is actually increasing, and in part it's because of drug resistance, and in part it's because of peri-urban slums, which are ideal environments for this to thrive in. So there are significant increases in some of these diseases coming our way. Little while to one where we were going to eradicate and eliminate very large numbers of diseases. And the reason this is dangerous is because if someone hears you say, I'm going to eliminate disease, what they hear is, I'm going to eradicate it. And when you've not eradicated it, they say you've overpromised. And even though things have improved, their view is, actually, why should we carry on funding it? Because you keep on promising us something and actually not delivering on it. So here is just a few of the targets to eliminate or eradicate, which are WHO targets by 2020. A little bit of maths will tell you that that's less than 18 months away. And I can guarantee that not a single one of those targets is going to be met. Now, they're going to be heroic failures. All of these diseases have improved massively. The graphs are going down. But people will remember that we've promised something, and they will hold that against us. They will say, and this is what happened to the malaria eradication, for example, in the 1970s. Malaria came right down, but because it wasn't eradicated, people gave up on malaria and disinvested for 30 years. So I think we need to be very careful of these rather high-sounding targets. Third one, a lot of people, I think, underestimate that epidemic infectious diseases have not gone away. And the really big one was clearly 100 years, the last really big one was 100 years ago, the 1918-1919 flu pandemic. And just for those of you who are not infectious disease people, this is to compare the influenza deaths with the total deaths in the US. These are the US influenza deaths against the total US deaths from World War I, World War II, the Korean War, and the Vietnam War. And one 2-year epidemic killed more people than all those wars put together, a point I sometimes make to my security colleagues. These diseases have not gone away, and we do not have a countermeasure to pandemic influenza yet, nor do I think we're going to get one in the next 10 years. So let us not forget this problem is not historic. But the huge change, and I want to go back to the positives on this, that have come from infectious diseases, have led to a stunning change in the pattern of mortality. On the life expectancy in years. And for those who can't read it at the back, this line here I'm demonstrating is deaths between the ages of 50 and 60. That was the year of the creation of the NHS, which we're celebrating the 70th birthday of both north and south of the border this year. If you speed forward, this graph looks remarkably similar, except what you don't see is that this graph starts right-hand corner. Now, many things flow from this, including some quite important implications for the UK, which I'm not going to talk about on this occasion. But one I think which is obvious, but I think needs to be said repeatedly, is this means that research which is done that is not labelled global is increasingly going to be relevant to the rest of the world, because actually we're converging on roughly the same sets of diseases. And the question is, what are the lessons that we've learned in high-income countries are applicable to countries as they move into this area, and which are the ones which we should quietly forget? But alongside that has been a very welcome change, though you wouldn't necessarily believe it from reading some of the worst sorts of newspapers. I have to say, not all in this country. And that is a clear thing in the last 15 years. When I became a doctor, it was still possible rationally to be a Malthusian, to say, well, it's all very well saving lots of babies. All this means is they're going to die of starvation because the population will explode. Reducing mortality in the adult population and the child population has tested one of two, a theory. There were two theories running alongside one another. One was the idea that this would lead to the population outgrowing all its resources. And the second was this will lead to people's fertility dropping as night follows day, provided you can provide female education and contraception. Absolutely clearly everywhere in the world, the second theory has proven to be correct on the data. And there is a very rapid drop in global fertility, which is continuing. Global fertility, where the steady state has now dropped to 2.5, and in Europe, we're now well below replacement levels of fertility at just over 1.5 children per woman born. So the stylized demographic transition is doing exactly what the textbooks say it should in virtually every country in the world, and people keep on trying to say, well, it's not happening here and it's not happening there. Actually, that's wrong on the data. Just to highlight some of the countries with a more than 30% reduction: Afghanistan, Pakistan, Yemen, States of Palestine. These are countries people, I think, just think it's impossible, and yet actually fertility is dropping as we speak. And the result is, even now, and this trend is going very fast, these are all the countries in the world in terms of their current fertility. Anything in dark Africa, and Africa meaning Africa south of the Sahara and north of South Africa, not the whole of the continent, which I think is often rather misleadingly implied. So a few of my more out there friends do occasionally say, well, it's all very well, but we're still going to have a crisis in Africa. Absolutely not. Africa is just a lot bigger and a lot more able to absorb things than is universally, I think, understood. This is a rather nice economist map which compares the scale. What it also does mean is that by the time we get to the end of this century, the ratio, the actual absolute proportions of the world's population in different continents will be radically different from what it was when most of us were born. So when the more silver-haired members of the audience were born, 20% of the, over 20% of the world's population was European, and the African population was less than 10%. By the time most of their grandchildren's have died, 45% of the world's population will be African, and Europe will be less than 7% of the world's population. That's an astonishing change around. If you want to know why it is doing global health is really important, just look at those numbers. And that's not just a global issue, it is also important when you look at individual countries. The UK, of course, over the last 100 years has moved from what we would consider a developing world population pyramid to a developed world population pyramid relatively smoothly. The same is not true, actually, for most of our European neighbours. That's for another day. But is also not true for many of the middle and lower income countries. Here, for example, is the population pyramid of Iran as a result of these changes. And what you can see here So this country is going to shift hugely in its social structure as a result of these medical changes in mortality and fertility. Same is true in a different kind of pattern to China. I think most people know that. A lot of people have not realized that South Asia is going through such a rapid demographic change. So now this is the population of Bangladesh. And what this means is Bangladesh is going to have the majority of its population, but the great majority of its population, of working age for most of the rest of our careers. If their economic policies are right, that's a huge economic opportunity. And because the average family is now caring for 1, 2, or 3 children, they can afford to invest in them, invest in their education in a way that was not possible when they were caring for 7 or 8. So there will be a secondary gain over periods of time. This is, and the same kind of pattern would be seen if you were, for example, looking at Latin America. And even in Africa, there are very many changes already, and these are going to be very quick. This is South Africa. The hollowing out you see due to in this graph is the fact that young women died of HIV. South Africa will be living with the consequences of that for a very, very long time. So it's only really in a small number of countries, most of which are in Central or West Africa, that we still have a population pyramid similar to the UK's 100 years ago. Most places it's changed very substantially. And therefore, as a result of this, we can say with some confidence that provided they live a reasonable So I talked a bit about infectious diseases, a bit about the demographic changes, which have big implications for how we should think about health in low and middle income countries. Increasingly, in my view, shifting away from a concentration on children, which has been very successful, and towards a concentration on young and older adults. And if the middle income countries now and the lower income countries in the not too distant future follow the UK pattern, what we expect then to happen is the infectious diseases are falling away. So we're expecting, if the history repeats itself, which sometimes it does, to see a massive rise in cardiovascular disease and mortality falling as a result of that. Is that going to happen? So these are the England and Wales data. And I think you can paint two pictures here, and both, in my view, are correct. The first of which is one that looks at the stunning improvements in cardiovascular disease that have occurred in high-income countries and say, why can middle-income countries not simply skip a generation and go straight to this? These are the reductions in under 75-year-old age-standardized coronary heart disease mortality since 1975 here in the UK. But when we look into the future, most of the things that are here, if you think about the attributable fraction for these, of course there's some very high-end stuff, there's open heart surgery and all that end, but actually the great majority of this is either primary or secondary prevention or changes in the environment. In fact, if you think about the attributable fraction, well, I've never yet found anyone in the UK who can tell me exactly what the attributable fraction of these are. And I think that is something someone could usefully do, because it would then work out which bits we could most helpfully translate from a high income to an emerging environment. And there are several reasons why I think things are going to head the wrong way on cardiovascular diseases. Air pollution and other environmental risk factors, again, I'm going to back these up with data, smoking, genetic factors, obesity and diabetes, affordable secondary prevention, and affordable treatment. There are going to be problems with all of these on cardiovascular diseases, even before we get on to the high-end interventions requiring high-income settings. So let's start off with air pollution. And I've done a few slides on this because this air pollution is relevant not just to cardiovascular disease, although it's very important for cardiovascular disease, but also particularly stroke. The attributable fraction of stroke that is due to air pollution, I think, is much underestimated. And in fact, many of my cardiovascular research colleagues, I think, falsely attribute to themselves and additional to this out of doors extrinsic air pollution, there's also the significant problem of indoor air pollution, which again, if you've gone back to the 1950s in the UK, when this was a big driver of cardiovascular disease, most people had coal fires to heat themselves in the winter. Not an issue now, is an issue particularly for cooking and in some areas of the world, heating around the world. So if you look at PM2.5 ambient air pollution, there are basically two broad patterns. The first of which is a large amount of air pollution over the Sahara. That is dust from dust storms. Don't worry about that because no one lives there. The really big problem is, of course, the large amount of air pollution. This is man-made, not desert-made, in the Cherai and northern India and Pakistan, and in particular in eastern China. But that is the direction of travel for the rest of the developing world over the next 30 years, unless we do something pretty radical about it. This is the sign of middle incomeness. And if middle incomeness is the same middle incomeness in Africa as it is in Asia now, this is going to follow as night follows day. It's not just PMs. This, for example, is sulfur dioxide, which is a precursor, very important for acute lung disease. Again, heavily concentrated in middle-income countries. It will come to Africa and Latin America fairly soon. And the result of that is that the big death mortality rates that you see around the world are going to be heavily concentrated in these highly developing countries. The second big one is smoking. Again, much of the improvement we've seen in cardiovascular disease in the UK has been due to a steady but highly effective anti-smoking series of measures with year-on-year reductions in every age group. One of the great public health achievements in the last 30 years. This, however, is not the case in very many of the countries that have got air pollution and are going into middle income. To do is invest in cigarettes. The market has decided this market has got only one way to go, and that is up very, very fast, because markets are forward-looking. So you've got environment, you've got smoking. Next, we move on to ethnic differences. We had a nice talk before the coffee break, which demonstrated in Scotland some of the cardiovascular ethnic differences. Here, for example, are some of the prevalence of diabetes differences you see in London, comparing people of South Asian, African heritage, direct or indirect, and white British. Everyone who's a doctor knows this. This is diabetes is an issue, hypertension is an issue, body distribution of fat is an issue. There are large numbers of genetic factors that are pushing more towards cardiovascular disease in exactly the same group. And let's look at obesity. This is the prevalence of obesity at the moment. I'd like to point in particular to South Africa. South Africa is simply showing where Africa is going to go over the next 20 years. So obesity rates are also going to rise. And with this, of course, is going to be increase in type 2 diabetes. So there's a list of things which are heading the wrong way, any one of which would cause problems, but if you put them together, environmental, smoking, obesity, diabetes, and genetics, you're actually looking at a very, very significant increase, which is not just because people are not dying of infectious diseases, that is important, but because there are very big drivers which we need to address head on. How about secondary prevention? I think what we can say is that many of the drugs which were developed these are Scottish data, and the market has actually operated in exactly the way that Adam Smith, that great Scots thinker, would predict it would, which is large amounts of competition for things that are off patent means the price has gone down even while the volumes have gone up. That is what has happened over time. It's a bit of an uptick because of the DOACs at the moment, but that'll settle itself down. So translating these drugs across for secondary prevention in middle income, high and low income countries is actually not going to be have a barrier due to cost of goods. The problem is the systems are not there to identify the right people and then to give them the drugs and monitor them. So it's a system failure, not a cost of goods failure. And I think people concentrate too much on the cost of goods. The cost of goods does not strike me as a barrier at all. So cardiovascular disease, my summary would be, A combination of demographic, genetic, environmental factors, smoking, means it's going to rise and fast. Primary prevention is very weak already, and it's heavily overwhelmed by economic interests. Secondary prevention is entirely economically viable in the sense that the drugs are not going to cost too much. The beta blockers, the aspirins, ACE inhibitors, all the statins, this is, you can get them very cheaply if you go to India or Brazil. But the systems are not in place, and we need to think seriously about how we support the systems so they are in place. And I do think that the cardiovascular community could learn a bit from the infectious disease community about how seriously to take on primary prevention. They have, in the UK in particular, concentrated far more, in my view, on secondary prevention, which is good, but I think for tackling these big drivers is not going to be sufficient. Cancer, before I come on to a few final points. I'm not going to talk quite as much about cancer because, in fact, in my view, a lot of cancer in low and middle income countries is largely unknowable at this point in time. But there are a few things which I think we can say with some confidence. Firstly, globally, as opposed to in the UK, a very high proportion of cancers are in fact infectious in origin, directly or indirectly via things like HIV. And therefore we can prevent them if we can prevent the infections. Secondly, smoking, obesity and air pollution are important for cancer, and basically everything I've said about cardiovascular disease is going to be relevant here. But when you come on to treatment of cancer, I think that the situation looks bleaker than it does in cardiovascular disease, actually. The bit where I think in complete reverse of cardiovascular disease, where I think cancer treatment does have an opportunity to do much better, is what was talked about before the break, surgical treatment of solid cancers, where I think we could do a lot better than we are at the moment. The bit which is not going well, for reasons of cost, is drug treatment that follows on. There are a few exceptions, things like tamoxifen in breast cancer, but by and large, the drug side is going to be seriously problematic. Again, let me back those up with data. This is cervical cancer incidence. And as you can see, although we have major programs to get rid of HPV here in the UK, and rightly, and Scotland's got fantastically good uptake rates, and I'm really proud of that, the fact is the big problem is elsewhere in the world, and particularly in southern Africa, and made worse by the fact that HIV is a co-risk factor for people having cervical cancer if they've got HPV. So we can get rid of this. Current vaccines, even the current quadrivalent vaccines, would get rid of the majority of this. And if we take the new 9-valent or 7-valent kind of vaccines, we have a serious chance to get rid of this as a problem in our generation. So I think that's one area we can look forward with some positivity. The second is liver cancer, where it's driven by hepatitis B or C. B, because we got a very effective vaccine, and C, because we've now got treatment which is astronomically expensive but falling incredibly fast. And my expectation is we will be able to treat hepatitis C with a short course of treatment affordably, at least in middle-income countries, within 10 years. So I think both of those I would expect, and before people go on to get their cancers. I've chosen female data here because they're much less complicated by alcohol, though not, I want to be clear, completely, before the women in the audience get too smug about it. But most of the non-infectious targets for primary prevention of cancer are bad or going the wrong way in middle-income countries and low-income countries, obviously including smoking, obesity, diet and alcohol, and pollution. Not in every country, but overall, these drivers are heading the wrong way, just as people get to the age where these are going to be significant potential burdens. When it comes to treatment, costs are going to be problematic on cost grounds for some time. And let's take prostate cancer, for example. We know that people of African origin, men of African origin, have a much higher incidence of prostate cancer from data from the US and elsewhere. This is going to be a serious problem in Africa, and I could go on some of the other cancers. And then we move to some of the treatments which depend on drugs. Surgery has no part to play generally in these ones except for palliation. And here, significant improvements, but are we going to be able to afford them? And this slide, I think, is very encouraging if you're an investor and very discouraging if you're a public health person. These are US data. I've chosen them from that socialist rag Fortune magazine that is explaining why it is that you should invest in drug companies. And what it's showing is purchasing power parity adjusted, so these data are nothing to do with inflation. Inflation has been stripped out. The amount that you would have to spend to get one extra life saved over time. And it's comparing, going back from 1996 to 2014. And what it's demonstrating in the US, UK data is slightly better, slightly different, is that we've moved from a situation where it was 50,000 per life saved to over 200 per life saved. That hasn't changed. You haven't bought anything with that money. You've just seen an increase in cost. These costs are completely impossible in lower income settings. So this is a really serious problem we're going to have to think through quite carefully. My final point is one about multimorbidity. What has happened? Now, in higher income countries, that has led to a significant problem which we're facing now and which the scientific community, in my view, is woefully unprepared to tackle, which is what we call multimorbidity. Multimorbidity, of course, is not a single entity. It is, in fact, a series of clusters of diseases that occur in predictable people in predictable combinations, which can be tackled as combinations. In higher income countries, the major driver of this is age, although socioeconomic status has a major part to play, and you can get multimorbidity combinations of diseases up to 20 years earlier if you come from lower down the socioeconomic spectrum in any country we're talking about. And this is to be true globally. But in the least wealthy countries, and here I'd go right back to the beginning on infectious diseases, the great majority of multimorbidity is in children, and it is driven not in any way by age, it is driven exclusively by poverty. And a small number of children will have very many diseases, almost all of which are either dietary or infectious in origin, clustered in particular people. And this is an area where I think the infectious disease folk, which includes me, need to learn a lesson or two from cardiovascular. Because we've concentrated almost always in low and middle income countries on mass primary prevention campaigns, mass vaccination, improving water supplies. So shift away from primary to secondary care. Secondary prevention, rather. So this global Usher Institute lecture is considered the change in global mortality happens from reductions in infectious diseases, essentially an incredibly positive story of which we as a generation, and I have to say we as the UK, because much of the science has come from this, some of the development money has come from this, can feel very proud. A change in fertility leading to substantial and irreversible demographic shifts, which is going to play through for the next 150 years, but the immediate effects of which are already on us and are, on the whole, very positive. drivers of cardiovascular disease, which in middle income and increasingly lower income countries are going the wrong way. So it's not just that people are not dying of infections, they're going to increasingly have pressures from other areas. A bit about cancer, some global trends, but a lot of uncertainty, particularly around cost. And then my final 2 points. The first is that we now have an enormous corpus of knowledge from people who would not see themselves as global health researchers, but who have learned lessons which can now be translated to the diseases of the developing world. So if you've gone back 20 years, actually 90% or more of all the stuff we needed to do had nothing to do with research in the UK. There was global research and there was UK research, and they were completely different researches. Increasingly, these are converging, and I see that the barrier between the two to be bad for both sides. I actually think a lot of domestic thinkers, particularly in public health, could learn a lot from the ambition and the way of thinking of the international thinkers. So I think something like the Usher Institute that brings together people who've got both global and domestic interests seems to me mutually beneficial and, more importantly, beneficial for health more widely. And we need to think seriously about which of the bits of the health improvements we've achieved we can basically take away and shift over, and which are the ones which are probably not going to be locally relevant. And then finally, the grand convergence that everyone knows is happening means that we need to move, and I've reversed my 2 final points, to a situation where what we're thinking about is increasingly not what the things are that can work, we know that, but how can we actually adapt the delivery mechanisms to local situations? And the answer to that is going to be very culturally determined, and is going to depend very much on which countries we're talking about. But these are entirely amenable to research, a lot of it in social sciences, and once we work that out, we'll be able to take a lot of the hard science lessons that we've learnt and translate them into the more softer science end and make them locally relevant to the countries that are entering what is going to be quite a changed environment. So several things going really well, several things likely to go badly, several things I think we could do to help. And you're in a great position to deal with the last of those. Thank you very much.
That was terrific. Thank you very much, Chris. So if we've got time for a few questions, if people would like to ask them. Can I have Chairman's prerogative and start with a comment and a question? You said at the beginning, so the comment is that you said at the beginning that falling fertility is always good. I'm not sure China would necessarily agree, where the fall in birth rate is so low that there's a worry about having enough young people to look after the aging population, particularly in the view of massive urbanization, which is happening in China. So I think I'm not sure that falling fertility is always good. And my question was going to be about rotavirus. On your rotavirus death slide, I think I'm right in saying that deaths haven't fallen in Africa, despite availability of the vaccine. Is that correct? And if so, why?
Yes, so on the first, and inevitably, because I was trying to trot through a huge area, I've simplified quite a lot of things. There are some situations where falling fertility, in its sense, it goes too fast or too far. But in general, the advantages of lower fertility are absolutely clear for individuals, for families, and for communities. On the rotavirus is really, the clear evidence that rotavirus was both effective and relevant to Africa is really pretty recent. So I'm expecting the big impacts of the rotavirus, in fact, to be seen in the next decade rather than now. But that's an example where, in fact, the fundamental shift we would need to do is to safe water and sanitation. And rotavirus is a good stopgap that will help reduce mortality in the intervening periods. And I have to say, it's also a technology that will be backward compatible. There will be environments where it's useful in higher income settings. But there is a bit of a lag time, but we now have the science to show this is going to make a very big impact. And it's certainly deliverable.
Okay, Jonathan Circle.
Jonathan Circle, Vice Principal and occasional endocrinologist. That was brilliant. Thank you very much. Absolutely fabulous. What do you think is going to happen to mental health disorders as people live longer and have more time to reflect on their condition?
Well, I think that there's firstly no secret in the fact that mental health disorders research has been relatively slow even in high income settings, and it is pitifully small in most lower and middle income settings at the moment. So I am very confident that as an attributable fraction of morbidity, it's going to go up. Even if the incidence stays the same, everything else is going down at such a rate that it's going to go up as an importance, and it's not clear who's addressing, as you imply, a very serious issue. There are, of course, two additional questions, which are, does a change in social environment lead to more mental health problems? And I think the answer, to be honest, is lots of different people have got very strong opinions based on not very much data. And the truth may be anywhere from it makes no difference at all through to it's going to make a very big difference. And I think if you've got 6 good psychiatrists in the room, you'd probably get a very major argument about this because the data are not there. But I'm happy to try and invite some if you want to test that out. But what I am very confident is that we do need to do a lot more on mental health research in every environment, in fact, including high-income settings. But this is a really, really underlooked event. And I was, for a year, the physician for the mental hospital in Malawi. It was the most depressing part of my professional life because there was so little you could do and so much serious morbidity with stigma and all the rest going alongside it.
Okay, Liz Grant.
Okay. I mean, we talked about young people and the demographic transition. Young people are the answer. How do you think we could draw together ministries of health and ministries of education to get collaborative, collective work so that one investment was, a shared investment and a meshed investment?
Well, I mean, I have to say, as someone who works in government, that it's surprisingly difficult, even in the UK, in its different constituent parts. But it is achievable. The problem is largely structural, and in this country and in many other countries, the money for education and money for health come from completely different areas. And in government, the key point is who pays. And unless you've got the money coming from the same source, you're never going to get this. So the key thing, in my view, may sound really, really dull, is to get the money stream the same stream from central government. And if that happens, then a lot of the kind of coordination on the ground will happen as a direct response to that.
There was next here. Yeah.
Thanks. Thanks for a lovely talk. Igor Rudan, co-director of Center for Global Health. So in global health, World Bank introduced this concept of cost effectiveness because there's just so many problems that you have to prioritize in some way, so cost effectiveness seems like a good idea, and then when UNICEF analyzed how this child mortality has been reduced, they realized something very strange, which is that if you are cost effective, you're not equitable. So basically, it's cheaper to save 1,000 kids in the central Bogota than to go out there in the villages for the same money. So as a result of that, they realized that we need to create an environment in which we can be both cost effective and equitable. And the research which is important to do that is so-called pro-poor research, which is to make the interventions that we already have more deliverable, more affordable, more sustainable, and so on. But nobody wants to fund that research, because it's not exciting, it's not novel, it's not interesting. So you get on the panels and you put in a decent proposal to make something more sustainable, which already is there, or more acceptable to people, and that's boring. That's not novel and it's not exciting. So who do we turn to get funding for such research?
Well, I think the first thing is to say is that there is a genuine trade-off between being equitable and being efficient. And that, anyone who pretends that you can be equally efficient and completely equitable simply does not understand how public health works. And if you've got a very limited budget, that trade-off is a serious difficulty. So you just have to be, and be honest about that seems to me the first thing. I absolutely agree, and that was the implication of my last slide, penultimate slide, was we should be finding the people who've got one health problem, because almost certainly they will have all the others, and by delivering secondary care to those people, we may be able to minimize the tension between these two. But one of the problems, speaking frankly as a funder, and I ran the DFID research for many years before this, was a lot of what I saw around equity was, in my view, simply rhetoric, with people saying we want to be more equitable, and then suggesting stuff that showed no evidence it was going to lead to a reduction in equity. It was simply going to demonstrate there was inequity. Well, we kind of know that. And so endlessly repeating the problem is not what we need. What we need is really rigorous science that will help us look at the most disadvantaged and help to improve their lot. Because, in fact, the big gains are, in fact, in that group. If you can reduce take the group who are the most disadvantaged and improve their mortality by 10%, your impact is much greater than reducing mortality by 10% of the middle income kids in that particular environment. So I think we should be doing it very seriously, but if we're going to do it, let's do it in a pretty hard-headed way and leave the rhetoric behind.
Yeah.
Hi, Chris. Mark Woolhouse from the Usher Institute. I agree with so much of what you said, but can I just take issue with your second last point there on technology? Like you, I'm not afraid to look in the future. I co-led a foresight project some years ago, over 10 years ago now, for David King, and we were looking at infectious disease diagnosis and surveillance. And the thing I think we got wrong with that, we said a lot of what you said, and we got that right, it was technology. We underestimated just how fast and all-encompassing the technological changes were going to be. And two areas where I think this is tremendously important for improving global health are diagnostics, where I think there's a massive amount that can still be done to make diagnostics available to the sort of populations we were talking about before the break. But also enabling technologies such as telecommunications, mobile phones, which have absolutely changed the landscape in so much, certainly of sub-Saharan Africa where I work. So I wonder if you'd like to say something positive about technology.
Well, I mean, I have the privilege to lead the organisation that probably does the most technological development in the UK for health, so I'm very pro-technology, and I think it's really clear that many of the big gains, and this is the point about the slide I made about malaria, that have been made so far have been made on the back of technologies. So I do not want this to come across as I'm not in favour of technology or do not believe it's part of the issue. And I think what is depressing about this is that the reason why we got so many technologies now and we did not have them 17 years ago is because of one couple, Bill and Melinda Gates. Until they started investing seriously in this, we simply did not have most of these tools. And once they started investing, lots of other people realised that these are things which are not scientifically particularly difficult. They simply have been underinvested in. And now we have a suite of technologies. We had a very nice thing about the RSV vaccines, for example, before the coffee break, which we simply didn't have before as a direct or indirect result of that investment. But, and the but on this, and I totally agree with your point on rapid diagnostic tests, is the health systems in most of the countries I'm talking about are not well equipped to use these rationally. And it's not that the individual practitioners are not rational, but the systems are not rational. And we've got to, in parallel with improving the technology, we've actually got to create a structure which can use that technology properly. So to take an example, and you've used rapid diagnostic tests, so I'm going to use my own research. It's the only thing I'm going to say on my own research here. I spent 10 years on rapid diagnostic tests in Africa. When I started with rapid diagnostic tests in Malawi, Nigeria, Kenya, Tanzania, really clear evidence that the great majority of people who had got a fever the doctor, if they had them, would ask for a rapid diagnostic test. If the result was positive, they'd give an antimalarial. And if the result was negative, they'd give an antimalarial. So they had the technology, and the technology was really good, but the system was not there to support them. So I think what I'm trying to argue against, I'm in favour of technology, but arguing against an idea that if you produce the technology, it will solve the problem. It is a partial and necessary part to the solution, but only that. And if we don't look at the delivery mechanism, the technology will fail, for sure.
I think in the interest of time, we're probably going to stop at that point, but I think Professor Whitty will be available when we have drinks afterwards, I hope, for further questions. And I'm going to pass over to Professor Sarah Cunningham-Burley, Dean of the Population Health Sciences, to give a vote of thanks. Sarah.
Thanks very much. So I've got the nicest job of the afternoon because actually I haven't been very involved in preparing the programme for the day, but I get to thank everybody. So first of all, I want to thank all of you for coming. It's not often that we all get together as an institute, and so it's so nice to see so many people here. But I also know that we have got other collaborators, members of our kind of much wider network, so you're very welcome to be here too. And I think you'll agree with me, it's been a really inspirational and really informative afternoon, whether you're engaged in global health research or not. And I really hope as an Usher Institute, and I'm sure that we will as an Usher Institute, rise to the challenge that Chris has given us really, and that is because we do global health research, and we do UK-focused domestic research, that we will be able to maximise, I think, the potential of the convergence that he has outlined for us. We're in a great position to do this. The Usher Institute is very collaborative in how it works and how we work together internally and externally, and we're truly interdisciplinary, and that was very clear in all of the talks today. And that we are engaged in both global and local research and across multiple sectors. And if one thing that's been really clear about all of the presentations today is the need to take the need to take multiple perspectives in order to deal with the pressing problems that we have. And the Usher Institute is also built on a legacy from public health. And so primary and secondary prevention is where we have to put our emphasis. So I think that we will rise to the challenge, but we've got an awful lot more work to do. Now, as an institute, we also benefit massively from the absolutely outstanding professional support staff that have really worked behind the scenes to make the afternoon kind of seamless, and the hospitality that precedes and will come after this as well. So I do want to thank that team in person, and I'm sure you'll all agree with me. So Dawn Katanach was our graphic designer, and you can see the impact of her work on all our kind of publications, etc. Laura Marshall, our events manager, Chris Burrows, who helped at the registration desk, Don Balharry with timekeeping and throwing that thing around, the technicians from Information Services Group for all our audio-visual support, so everything's worked really well, which is fantastic. Our catering from Edinburgh First. And most importantly, Susan Buckingham, who's our comms manager, who's coordinated everything. We are a large institute. It was a very, very big programme to coordinate this afternoon, and so thank you to all of you. Also, I want to thank all the speakers and the poster presenters today as well. It's been fantastic to hear all of that. Also to thank Harry, who was convened the kind of programme development, Peter for being here, and Aziz as director of the Usher. So now I want to thank Chris himself for coming up to provide our third lecture. So I learnt an awful lot today. It was a really well-crafted presentation, and particularly being able to take a kind of global wide view, but then kind of telescope in to something that was much more specific, come back out to the bigger view, back in again. And I think you did what all sociologists require of us, to focus on context, 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 and then step out again to see what that context means. And also to take the long view, both looking back at what's happened that will help us to identify what's going to happen, and a sense of what we can do now that will intervene in a way that will make your projections more positive in terms of the health of all our populations. So it was really very, very useful for all of us to hear that, and also the kind of humility of where medicine cannot provide the solutions, that you identified, as public health has always done, the clear socio-economic drivers of ill health and where we need to intervene to really make a difference. So on behalf of everybody here and the Usher Institute, I'd particularly like to thank you, and we have a small gift. You don't have to stand up to receive it, you can stay there. Thank you very much indeed.